Hello everyone. Today we are going to learn about the skull radiography. There are few imaging modalities of skull radiography. First one is plain radiography of the skull. It divided two main parts, basic views and special views. Then computed tomography, it means CT of the skull. Then magnetic resonance imaging, it means MRI. And then nuclear imaging. Now we are learning about the anatomical terminology. First, landmarks. The outer canthus of the eye. It means the point where the upper and lower eyelids meet laterally. Then, infraorbital margin or infraorbital point. It means the inferior rim of the orbit with the point being located at its lowest point. Then nasation. The articulation between the nasal and frontal bones. And then glabella. It is a bony prominence found on the frontal bone immediately superior to the nasation. You can remember it, immediately superior to the nasation. Next one is the vertex. Vertex is the highest point of the skull in the median sagittal plane. Do you know about median sagittal plane? I think you all know. Next one, external occipital protuberance. It is a bony prominence found on the occipital bone, usually coincident with the MSP. It means median sagittal plane. Next one is external auditory meatus or EAM. It is the opening within the ear that leads into the external auditory canal. Okay. There are the anatomical terminology. You can see these pictures. This is the vertex and this is glabella, nasation. So this is the infraorbital point and external auditory meatus or EAM. So you can see some baselines also. You can refer these pictures. Then external occipital protuberance. So these are the terminologies, and you can see the median sagittal plane from this picture and interorbital or interpupillary line and infraorbital line. It is inferior to the orbits. You can see the infraorbital line. So now we are learning about the lines. First one, we have learned about the landmarks. Now we are moving to the lines. First line, interorbital or interpupillary line. It is line joining the centers of the two orbits when the eyes are looking straight forward. Then infraorbital line, line joining the two infraorbital points. Then anthropological baseline or ABL. It is passes from the infraorbital point to the upper border of the EAM, also known as Frankfurter line. See this picture. There is anthropological baseline. This is that line. Passes from the infraorbital point to the upper border of the EAM. Next one is orbitometer baseline or radiographic baseline. extends from the outer canthus of the eye to the center of the EAM, approximately 10 degrees to the ABL. See these pictures. Look at these all lines. This is median sagittal plane, internal orbitally or interpupillary line. This is infraorbital line. See, this is A. A line is orbitometal or radiographic baseline. The B line is anthropological baseline. Okay, now we are moving to the planes. There are few planes. First one, median sagittal plane. You all know this plane. Median sagittal plane, MSP, divides the skull into right and left, two equal halves. Landmarks on this plane are the nasion anteriorly and the external occipital protuberance posteriorly. Then coronal planes. These are at right angles to the MSP and divide to the head into anterior and posterior parts. It's so simple. Next one, axial plane. A horizontal plane which divides the skull into superior and inferior parts. It means superior and inferior parts means up and down. Then anthropological plane. A horizontal planes containing the two ABLs and the infraorbital line. It is an example for an axial fan. It is also an example for the axial fan. Then auricular plane. Perpendicular to the anthropological plane, passes through the center of the two EAMs. It is an example for the coronal plane. So now look at these pictures. You can see the median sagittal plane and the coronal plane and the axial plane very clearly. This is an X-ray machine. Now we are moving to positioning terminologies. Occipitofrontal OF or posterior anterior projection, it means PA. You can see these pictures. Frontal bone or anterior aspect of the skull is touching the tabletop. See this? Then erect buccal or surface. This is the tabletop or this is the erect buccal surface. When the patient is lying in this way, it is called as prone position. This is prone position. Next one is fronto-occipital or anterior posterior projection. It means AP. Occipital bone or posterior aspect of the skull is touching the tabletop. You can see this picture and or erect buccal. This is the tabletop and this is the erect buccal surface. When the patient is lying in this way, it is called as supine position. This is the supine position. You can see this is the skull unit. This is isocentric skull unit. Position of skull unit for basic position. This is a basic position. Now, the advantages of a skull unit can be more comfortable for the patient. Reduction in image distortions and high resolution images. Perverse designs, circular collimators allow close collimation to the head. reducing the patient dose and minimizing the secondary radiation. Again, the advantages of the skull unit can be more comfortable for the patient. Reduction in image distortions. High resolution images. Purpose designed circular collimators allow close collimation to the head, reducing the patient dose and minimizing the secondary radiation. Then, the disadvantages of the skull unit. The table is quite narrow and difficult to get on, unsuitable for patients who are unable to cooperate and for patients with thoracic hypoxia since they may fall off. Radiographer should acquire a set of skills unique to the equipment. Units are expensive. Then lateral projection. Either side of the skull is touching the tabletop or erect bucky surface. There are some examples. Right lateral, it means right side of the head is closer to the image receptor. Left lateral means left side of the head is closer to the image receptor. You can see these pictures. Please look at these pictures and you can refer these pictures. See, first picture is right lateral. This one also right lateral. So this picture is left lateral. Then this picture also left lateral. Then patient and equipment preparation. Patient preparation. Ensure that all metal objects are removed from the patient's skull region. First, we have to remove all metal objects from our skull region. Example, some hair clips and hairpins. Next one, bunches of hair often produce artifacts and thus should be untied. We should untie our bunches of hair because it may be there are some artifacts from that bunches of hair. Then next one is the patient should be provided with a clear explanation of any movements of X-ray machine and image receptor positions associated with the technique. Then instructions related to the technique should be given to the patient. Give appropriate radiation shielding garments to the patient. There are some gonadal shields, eye goggles, thyroid collars, such like providing shielding materials. Then the equipment and accessories preparation. First, select the suitable cassette size according to the size of the patient. Then, position the site marker properly. Place the cassette correctly in the erect bucky or table bucky tray. Prepare X-ray tube according to the examination. It means FFD 100 cm for all the skull projections. Prepare the other useful accessories such as immobilization devices. When needed, immobilization devices means some immobilization pads, velcro straps, 45-degree triangular foam pads like that. So you can see from this picture, when you look at this picture, you can see some immobilization devices in here and here. So that's all. Select the exposed factors correctly according to the examination and the patient size. So you can find out about that exposure factors like KVP, MA, MAS, that type exposure factors. So find out and refer that.